All right, so now the heart. Now, in conjunction with this, there's another lecture that you'll find called Congenital Heart Defects. And it's part of this as well. There is a little bit in congenital heart defects as we'll talk about here, but I'm going to blow through that in lieu of the more comprehensive version of this in just a second. All right, so the cardiovascular system we've already talked about, transporting the heart, blood vessels. All right, heart is both the driving force and the limiting factor for this whole thing. It makes it work, but if it doesn't work, this is not going to work by itself. So rely on the heart. Now the heart starts as what's called embryonic mesoderm, and we'll go into this development of the heart when we look at congenital heart defects. Here's an overview. I'm going to blow through it right now, and we'll come back and talk about it in detail in your congenital heart defect lecture in just a bit. In addition to that, we'll talk about these fetal structures that are going to bypass as well. Don't ignore this. We're going to go back over it in a minute. All right. So, the heart, what's the heart thing here? Right here, where the heart is. Heart, yeah. There, awesome. Sac around the heart is called the pericardium. A double-walled membrane. You see the double wall right there, filled with fluid. Its job to prevent friction between the heart and all the stuff around the heart. The muscle of the heart is called the myocardium. Heart. And the endothelium that lines the heart is the endocardium. The epicardium is sort of the outer layer. It's really the pericardium. There we see that. Cardiac muscle bundles. That shape is telling. We've got two upper chambers and two lower chambers. The upper chambers are going to push blood down so that when these bundles of muscle contract up here, blood gets out. When these bundles of muscle down here contract, blood gets squeezed up and out. So 4 chambers of the heart, 2 atria, 2 ventricles. Atria, the upper chamber. Atria, I don't actually remember what atria means. So the atria, receiving chambers, ventricles, discharging chambers. The walls of the atria are bridged by these muscles called pectinate muscles, fine little bands of muscle. And let's look. So the right atrium, hallway. The right atrium, low oxygen blood from the body through those big blue superior and inferior vena cava. The left atrium, high oxygen blood from the lungs to the right and left pulmonary veins. Ventricles are discharging chambers. The muscle here is thicker. It's called trabeculae cardae. Trabeculae, if you'll remember, is that sort of lattice that we see in spongy bone. Cardae means meat. So these are thick bands of muscle. Some of them actually project out into the cavity of the ventricle. They're called papillary muscles. Off the right ventricle, we've got the pulmonary trunk, and off the left ventricle, we've got the aorta. Pulmonary trunk right there. The right ventricle pumps low oxygen blood out to the lungs through the pulmonary arteries. The left ventricle pumps high oxygen blood out to the body through the aorta. What's the difference? You cut that heart in half, you can see the difference between the right and the left ventricle. The left ventricle has to pump blood out to your feet. The right ventricle's got to pump blood out to your lungs, and they're right freaking there. Like they're not 2 inches away. The right ventricle doesn't have to do a whole lot at all. The left ventricle does all the work. They hold the same amount of blood, but the walls of the left ventricle are thicker because it does have more work to do. The heart is really 2 side-by-side pumps. A pulmonary circuit that carries blood to, not and from, to the lungs. And the left side is the systemic circuit. Brings blood to the body. Here's another. Again, organization. Systemic circuit. Pulmonary circuit. Let's talk pathway. This is important. You need to know the pathway of blood through the heart. You have to know. One, it's going to be on your exam. You're welcome. Two, it's going to come up again. Oh, like a lot. So let's start in the right atrium because that's convention. So, from the right atrium, so that's low oxygen blood. It's going to drop down through the tricuspid valve and into the right ventricle. Then from the right ventricle, it's going to go up through the pulmonary semilunar valve, up and out the pulmonary trunk, through pulmonary arteries to the lungs. Now, what happens in the lungs? Well, the blood picks up oxygen. Now that it's picked up oxygen, it comes back to the heart through pulmonary veins, the left atrium, and through the bicuspid valve, down in the left ventricle, to the left ventricle, out the aortic semilunar valve, to the aorta, and then out to the body. And then in the body, it loses oxygen, and this process starts over. There's another great view of this. Low oxygen blood, high oxygen blood. Make sure that you can do the pathway of blood through the heart. Equal volumes on both sides. The pulmonary circuit is short and low pressure. The systemic circuit, there's lots of resistance, so there's another view of that. Right and left ventricle. The heart's also pumping blood to itself. This is called coronary circulation. On the right, arteries and veins here. The arteries include the right and left coronary arteries, marginal, circumflex, anterior, interventricular. Veins, cardiac veins. Let's look at some of them. The aorta drive to the left coronary artery. You can't see this, but kind of up and under the aorta. Right here, there's a left coronary artery. That left coronary artery is going to do two things. We come over here and branch into this one. It's called the anterior interventricular artery. And then it's going to circle around here to the side and become the left circumflex artery. The left coronary artery supplies the whole front and the left side of the heart. The aorta also gives rise to the right coronary artery. There is a right marginal artery that goes there. And then it comes around the back of the heart and turns into this posterior interventricular artery. Supplies some of the back and right side of the heart. Fun fact. Left coronary artery typically supplies about 75% of blood to the heart. Which means that damage or blockage in this left coronary artery is 75% of your heart. Oh, wait. All right. Veins. Blood's going to come back to the right atrium to the coronary sinus, which you see right there. It's going to receive blood from the great cardiac vein, the big blue one in the front, the middle cardiac vein, the big blue one in the back. Some of this in line. Atrioventricular valve on the inside. So atrioventricular means between the atria and the ventricles. We have two. One, two. The right side here is called the tricuspid valve. Tricuspid on the right. bicuspid on the left. Bicuspid valve, sometimes called the mitral valve, because someone thought it looked like a mitre, which is the hat that bishops wear. Yeah, I don't see it. Things with the AV valves, bicuspid, tricuspid. Those two valves open to let blood go from the atria to the ventricles. They close when the ventricles contract. The edges of those valves are connected through these little strings called chordae tendineae. Chordae tendineae connect to these papillary muscles, little outshoots of muscle there in the ventricle. And what happens is when the ventricle contracts, it pulls on those little strings so that blood that's here can't go back up. It keeps that valve closed. It prevents prolapse of the valve. Prolapsing would be the valve back, allowing backflow or opening up so that blood can escape. All right, 500 muscles, extension directly cardiac, these big ridges do that. All right, so two AV valves, bicuspid and tricuspid on the right, bicuspid on the left. We have two semilunar valves, and you can see one right there. There is a pulmonic or pulmonary semilunar valve. It's between the right ventricle and this big purple pulmonary trunk. And then there's an aortic semilunar valve, which you can't really see, but it's back up there between the left ventricle and the aorta. These open when the ventricles contract. Remember, these AV valves close when the ventricles contract. Semilunar valves open when the ventricles contract so that blood can go up and out to wherever it's going. They close when the ventricles relax. These don't have strings or muscles supporting them. All that keeps them open or closed is pressure. There's pressure here in the blood vessel that pushes back on that valve and keeps it closed. Here's a great view of these mechanical events of the heart. The blood's going to come back in. To the right atrium, in this case. It's going to drop straight through down into the right ventricle. The ventricle fills, it closes that valve, the AV valve, and the ventricles contract. The ventricles contract, pressure builds up, and it forces blood up and out the semilunar valves to the aorta of the pulmonary trunk. When the ventricles relax, the pressure inside those vessels drops back down on those valves and forces them closed. We'll review cardiac muscle. It's something that we did talk about last semester. Cardiac muscle cells are short, they're fat, they're branched. They look like that. They're connected by intercalated disc. The intercalated disc contains the gap junction and a desmosome. Gap junctions are electrical connections between cells. Desmosomes are like spot welds between cells. Desmosomes keep the cells from moving apart. Gap junctions ensure that the electrical impulse travels from cell to cell. We say that the heart behaves as a functional syncytium. That means the heart acts like one big heart-shaped cell because all those cells are interconnected. Heart muscle contraction is spontaneous. It's autorhythmic. It's automatic. That's because there are pacemaker cells in the heart. They depolarize on their own. You don't need the brain to tell it to do this. If we were in lab now, what we would do is we would, how do I put this? We would murder some frogs for science. I mean, euthanize some frogs for science. We would drive a needle into the brain of a frog, swish it around, and then take the needle and shove it down the frog's spinal cord and swish it around so the thing wouldn't jump. So its heart's going to keep beating because there's some diffusion of oxygen and carbon dioxide because of the way amphibians work. So now you've got this dead frog, super dead, no pain, for science. but its heart's still beating. Why is its heart still beating? Because those pacemaker cells are on their own. They don't need the brain. Now, the brain has some oversight, but the heart beats by itself. Now, there's some difference here between cardiac action potential and skeletal muscle action potential. There's a really long absolute refractory period because of calcium influx. This is stuff that we talked about in AMP1, so I'm not going to spend a whole lot of time here. Here's the graph. Here's our cardiac action potential. Now, if I was going to draw the skeletal muscle action potential looks like this. It's straight up, straight down. It's over and done. What that means for skeletal muscle is that we can do that, and we can add another one, and another one. And skeletal muscle contraction can do this. Skeletal muscle is capable of temporal summation. Temporal summation doesn't matter because freaking cardiac muscle can't do that crap. This long absolute refractory period here prevents temporal summation in cardiac muscle, which means that because of this long absolute refractory period, cardiac muscle has already relaxed before you can fire another action potential. Now, again, I'm not going to get into the calcium influx thing. Again, we did this. Cardiac muscle contraction is triggered by pacemaker system, conduction system of the heart. The conduction system of the heart is powered by cells with unstable resting potentials. Now, remember, in most of your cells, you have this resting membrane potential that's set by that sodium potassium pump and this potassium leaking. In these pacemaker cells, they leak sodium. So sodium is always coming back in. You never get a flatline resting potential with that. So sodium in. Once you reach the threshold, you get calcium influx and then potassium out. Sodium's already coming back in. Notice there's never a flat line. It never goes horizontal on you. It's always coming pacemaker potential because it leaks sodium. Here are our components of the conducting system. Can't see this. I couldn't show you this in dissection. Start at the SA node or the sinoatrial node, right there at the top of the right atrium. In between the SA node and the AV node, which is called the atrioventricular node here at the bottom of the right atrium, we have these internodal pathways where we have conducting cells. From the sinoatrial node, we're going to go down this atrioventricular bundle, or the bundle of His, and then back up these things on the side called Purkinje. The pacemaker of the heart is the SA node. It generates sinus rhythm about 75 beats a minute. It's the fastest part of the depolarization process. So cells here depolarize. They're the first ones to do it. And that impulse is going to travel around the atria and then collect back here at the atrioventricular node. Now, once it gets to the atrioventricular node, it's going to slow down. There's not as many gap junctions, and the fibers are smaller, so we get a delay. Take that SA node out, and the AV node becomes the pacemaker. And it only depolarizes about 50 times a minute. We can call this a junctional rhythm. Junctional rhythm is when the AV node takes over as the pacemaker. It's a little slow. So the atria contract, down. That delay at the AV node is there to give time for the blood to move. So blood goes down, and then the impulse travels from the atrioventricular node down the Purkinje, down the bundle of His to the apex or the pointing end of the heart. Here's the thing. That bundle of His, or the atrioventricular bundle, I keep picking the wrong thing, here, is in the fibrous skeleton of the heart. It is not touching cardiac muscle, which means it's electrically insulated. Because that impulse is going to go here, and it's going to go all the way down to here, the apex, where it touches the muscle. That bundle of His is the only connection between the atrium and ventricles, and it's in this fibrous skeleton of the heart. Then we have the right and left bundle branches and the Purkinje fibers. We're going to go down here and come back up. Now, the Purkinje fibers are touching the cardiac muscle. So that impulse is going to spread through the cardiac muscle, and the ventricles are now going to contract. What that means is that the ventricles contract beginning at the apex. That impulse travels from here all the way down to here. Nothing happens. Then it comes back up the sides. Now it's going to contract. So the ventricles contract starting here, which is awesome because you want blood to go back up this way, right? You want the heart to start contracting here and squeeze blood up and out. You don't need it to start here because then blood would have to go down and then come back around, and that's stupid. So the heart starts contracting at the apex because that bundle of His is in the fibrous skeleton of the heart. All right. That entire thing took 225 milliseconds to happen. It's a heartbeat. Here's another view of these cells, these structures. Remember, you cannot see this. You won't see this on your lab exam because if I was dissecting a cadaver, I could not show it to you. It is microscopic. Now, while the heart beats on its own, that's not to say that the brain doesn't get some oversight. The heartbeat is modified by the brain, the autonomic nervous system. Even the conscious control, you can modify heartbeat. Cardioacceleratory, cardioinhibitory center in the medulla. Obviously, sympathetic things make your heart beat faster. Parasympathetic things make your heart beat slower. Let's break that down a little further. Parasympathetic, your neurotransmitter for the parasympathetic branch is acetylcholine. Your neurotransmitter for the sympathetic branch is norepinephrine. Obviously, norepinephrine makes your heart beat faster, but acetylcholine makes your heart beat slower. Hold on to that idea. We can look at all this electrical crap in your heart with an EKG. We'll have a demo video for this shortly. I'm going to find a child to volunteer shortly and do an EKG on him. Why do I have an EKG machine in my house? Why don't you? Stop it, judging. So I have an EKG. We'll do. We'll get P wave, QRS, T wave. That P wave represents atrial depolarization. Notice you get this little flat line right there. That your delay, the AV node. Then you get ventricular depolarization, so that's the AV node all the way down those bundles and back up Purkinje fibers. And then you get ventricular deep repolarization. So look, atrial depolarization causes the P wave. There's that little flat line right there. The delay, ventricular depolarization, ventricular repolarization. Here's a normal rhythm. A normal rhythm comes a sinus rhythm. Here's a junctional rhythm. Notice there's no P wave. You get QRS, T, QRS, T. There's no P wave. This is called a second degree heart block. The second degree heart block, you get P wave, QRS, T, nothing. See that? Here's your T wave. There's another P wave. Wave is, you get a P wave, nothing. P wave, then you get your heartbeat. So that means that the AV node is working, but right here, some of those impulses aren't getting passed through. So your heart is skipping a beat. And then here is fibrillation. Fibrillation is irregular, uh, uncoordinated impulse. They're not working as a functional syncytium anymore. They're just randomly depolarizing. You've got two types of fibrillation, AFib and VFib. Atrial fibrillation is this fluttering of the atria. Not a massive thing. I mean, it's not great. It's not, you're not going to drop dead. VFib is really bad because that means your ventricles aren't pumping blood out to your body. When we hit you with, you've heard the sounds of the heart. Those are the valves closing. A heart murmur is just an abnormal heart sound caused by the valves. Here's where we listen to the heart. All right, cardiac cycle. Here we go. Systole is contraction. The first thing that happens is filling of the ventricles. Now you're thinking, don't the atria fill first? Not really, because the valves between the atria and the ventricles are open. So blood just drops straight through. About 80% of blood just drops into the ventricles. When the atria contract, it only shoves a little bit of blood, whatever's left, down into the ventricles. This brings us to our first important value, the end diastolic volume. This is the amount of blood in the ventricles at the end of ventricular diastole. Translation. Blood went in. How much blood went into the ventricle? End diastolic volume. Stick with it. Then the ventricles contract. Atria relax, ventricles contract, pressure goes up, and we shove blood out. This brings us our second value. End systolic volume. In systolic volume is the amount of blood that's remaining in each ventricle at the end of ventricular systole. Translation, this is blood left behind. This blood did not make it out of the heart. It's the blood that's still in the heart. So now, quick math. We take how much blood went in, subtract whatever blood is left over. That tell us how much blood went out. And that is called stroke volume. Volume is the end diastolic volume minus the end systolic volume. How much blood went in minus how much blood is left over. That tells us how much blood went out with a heartbeat. And that's what the stroke volume is. The stroke volume is how much blood exited with that heartbeat. So now, take stroke volume, how much blood goes out with a heartbeat, and we multiply that by the heart rate, beats per minute. Then we can get volume per minute. That is cardiac output. Oh, well, there's a slide that shows that. That was convenient. Cardiac output is the amount of blood that's pumped out by a ventricle in a minute. At rest, cardiac output, your heart rate's about 75 beats a minute. More if you're me and you're drinking coffee at midnight. And your stroke volume, let's say about 70 milliliters a beat. That's about 5.25 liters a minute. Your maximum cardiac output, if you're not an athlete, it's like 5 times that. If you're an athlete, maybe it's like 7 times that. The cardiac reserve is the difference between those two things. Stroke volume is important. And there are three things that affect stroke volume: preload, contractility, and afterload. All right, let's do this. Preload, technically, is the degree of stretch of cardiac muscle cells before they contract. The Frank-Starling law of the heart tells us that increased stretch of cardiac muscle increases the force of cardiac muscle contraction. English. If you stretch out heart muscle, it contracts with more force. What would stretch out heart muscle? Putting more blood in. Increased venous return stretches out the heart, which increases contraction force. So let's do this. Increase preload. What we're doing, we're increasing end diastolic volume. We increase the end diastolic volume, we increase stroke volume. Translation, you put more blood in, you get more blood out. If you increase stroke volume, what happens to cardiac output? Obviously, you increase cardiac output as well. You put more blood in, you get more blood out. Excellent. Contractility is how hard the heart contracts, regardless of the blood flow. Forget how much blood's going in. How hard does your heart contract? Well, that's controlled chemically. An inotropic agent, or an inotrope, changes contractility. It changes the force of the heartbeat. A positive inotropic agent increases contractility. What's a positive inotropic agent? Calcium influx. Causes calcium influx. Epinephrine, norepinephrine. Anything that acts like epinephrine or norepinephrine. Anything that acts like the sympathetic nervous system. Anything that's a sympathetic mimic. So we're talking caffeine, epinephrine, norepinephrine, crystal meth, cocaine, regular amphetamine, all of those things, Adderall, that act like the sympathetic nervous system. Those would be positive inotropic agents. They make the heart beat harder. Now, a negative inotropic agent decreases contractility. It makes the heart beat with less force. Your major negative inotropic agent, potassium. Potassium weakens the heartbeat. Also, medications, calcium channel blockers. Calcium channel blocker is another thing that we use to fight hypertension. By blocking that calcium channel, we negate the effects of epinephrine, norepinephrine, and the heart beats with less force. More on blood pressure. Acidosis will also decrease contractility. We're not going to get into this. Here's why norepinephrine works with those calcium. The last thing. Oh, let's go back. So, contractility. If we increase contractility, the heart beats with more force. The heart squeezes the blood harder, which means there's less of it left behind. That decreases the end systolic volume. Right, in systolic volume is the blood left behind. Now we're going to decrease that. So decrease the end systolic volume. Again, increases the stroke volume and increases cardiac output. If your heart beats harder, you pump more blood out. Well done. The last thing is afterload. Afterload is the pressure your heart has to beat to get blood out. All right, so take a second and let's work on this analogy here. So, car tire. Expertly done. So, when you put air in your car tire, why don't you use a bicycle? Well, your bicycle doesn't generate enough pressure. There's more pressure already in your tire than the pump can generate. If you ever try this, please do not stand above the bicycle pump, because when you connect that nozzle to the little valve to the valve stem on the tire, that pressure is going to push that handle up on the bicycle pump, and you're not going to be able to push it down. You can't generate enough pressure. In order to get air into the tire, the pressure in the pump has to be higher than the pressure in the tire. So we use an air compressor. After load. In order to get blood to leave the heart has to put more pressure on the blood than what's already in the blood vessels. So if your blood pressure, your mean arterial pressure, is already high, the heart has to work harder to get blood out. If we increase afterload, we increase the in-solid volume. I mean, there's more blood left over because we're pushing back on the heart. Decreases stroke volume and decreases cardiac output. Hypertension increases the afterload. Chronotropic factors change the rate of the heartbeat. A positive chronotrope makes your heart beat faster. Things like epinephrine, norepinephrine, those make your heart beat faster. Negative chronotropes slow down your heart rate. Things like acetic. The sympathetic nervous system plays a large part in this because it does increase cardiac output, makes your heart beat faster, it increases contractility. The parasympathetic nervous system works against that. It opens potassium channels, it slows down the heart, and makes the heart beat with less force. And we're not going to worry about this, so just ignore the Bainbridge reflex right now. All right, so there's our overview of the heart. Now, your next lecture that you need to look at is congenital heart defects. Development of the heart. We'll talk about the pathway of blood through the heart again. The next one you want, congenital heart defects.